All right, everybody. So tonight we're going to do the part 2 of the concussions talk that we started last week. Last week we kind of went over some of the broader bits of information, history and the different types and the 3 levels, those kinds of things. Today I wanted to talk more about what baseline is, how we diagnose them, how we treat them, and how we return somebody to play, to work, or to learn. So to start off, I'm going to talk about baseline. So in 2015, baseline testing became quite popular, and the test that we used was called the impact test. And impact is a computerized, standardized testing, meaning that no matter where you are in the world, when someone says impact test or baseline, we know that this particular neurocognitive test is part of it. And the nice thing about having a baseline is that, you know, you sustain a concussion. I've got some normative data to go back and compare it to. The problem we found out is that the teenage brain and the youth brain changes quite drastically about every 17 days. So what we were noticing is what we thought was a baseline, let's say in August, and you sustain a concussion in January, well, now we couldn't rely quite as heavily on that baseline data. But regardless, it's still a very, very useful tool. And so we started doing baseline for Laurentian 6 main teams. So the 2 basketball, 2 soccer, and 2 hockey teams. We did baseline for Cambrian's cross-country, soccer, and volleyball teams. And then we did, you know, random hockey teams throughout the community. So gathering all this data, along with the neurocognitive piece, we would also test SWAY or BESS, B-E-S-S, which is a balance test. We would also do some hand-eye, depending on what sports you were at, what you were playing. We would do some other exertional pieces to it. Sometimes it was like a grip, so you would hold. It was a meter stick, and what we would do is we would stick a puck to the bottom of it, and you would clench it. You would drop it and clench it again, and how quickly you could react was something that we would record. And that was all part of your baseline. And of course, we would use that to compare to when it was time to consider your return to play. And in 2015, like I said, impact became quite popular in Canada, very, very popular in Ontario. And it was for the first time in the 20 years I had been, working, the first recordable data that we could use to help determine how ready you were to return. In about 2016, I started to question whether I could use this data efficiently and effectively or not. And I started questioning whether I wanted to continue to do impact testing. And the reason was because the brains were changing, and it was $20 every time I tested them. And sometimes they scored better post-concussion than they did in their baseline. And then that really threw off what I was using this baseline data for. And it really wasn't serving the purpose that I had intended it to serve. So I stopped doing large groups, and I would do the odd one. And what I started using the baseline for in 2016 and early 2017 was just cognitive function. So memory, perception, normal brain function, reaction time, things like that. And I was using that to see whether I could use it as a tool to return them to learn. Like if you couldn't cognitively do the test, and a test that should have taken 20 or 30 minutes took you 90 minutes and gave you a headache, well, I was using that as a return to work, to return to learn piece, as opposed to a return to practice or play piece. And I was using that to determine whether or not that concussed person would be effective at returning to cognitive, so work, reading, those kinds of things. And shortly in 2017, I actually got out of treating a lot of concussions, because the concussion management courses were weekend courses. And I soon found that we really weren't taught well enough to say we could manage a concussion. And they made us feel as though they had given us all the necessary tools we would need to bring an athlete from the day of the concussion all the way back to their sport. And that was not correct. And it actually, I believe, created a false sense of security, and definitely a false sense of information and education. So I backed out for a while, and I went and studied at the University of Pittsburgh's Medical Center, so UPMC, which is the facility in the States that Sidney Crosby was treated at, and I feel the epicenter of what created a concussion management protocol to this day. And not that I wish anything on anyone, but Sidney Crosby definitely created a change in the platform that we now treat concussions with. And for that, obviously, anybody with a concussion, we're forever grateful. So I worked with the medical science group there, and quickly realized that the little bit of information that we could possibly have learned in a weekend course was nowhere enough. Then back in, I would say last year, because of my sports teams and because of my connection to the sporting world and to the Sudbury community, I decided that I had to have some connection with concussions because they were coming to me regardless. And so I started with a team called Complete Concussion Management, Inc. out of Toronto. And this is a team of 9 healthcare practitioners with neurologists, ophthalmologists, naturopaths, chiropractors, physiotherapists, sports medicine doctors, a group of 9 practitioners that every single week on Tuesday review all the research that came out on concussions for the entire week. They group every Tuesday and they make the necessary changes to the protocol. And if the protocol is exactly where it's supposed to be, they high five each other and say, okay, no changes this week. And if some information resurfaces, basically, they will make those changes, and thus we make those changes. And their program for the education piece was much more substantial than a weekend course. And it took me several months to actually complete. And they gave us all the documents to use. They gave us the documents to educate the community, the physicians. And what they taught us to do was know your limitations and use the outside network that you have. So use other healthcare practitioners. And I was very, very impressed with the fact that nobody tried to keep that concussed person or athlete to themselves and take them from day one all the way to the very end. Because I'm not a vision expert. I'm not a neurologist. I'm not a vestibular therapist, and I'm not a speech therapist. So I can't do those 4 things. And, you know, in the other avenue in 2015, that's what they made us believe, and that's what we were expected to do. And then, you know, later on realizing that that's really poor judgment and not the direction I want to take my patients through. So with that said, that's kind of like the evolution for me with concussions. Now we have a really, really good spreadsheet and platform that we work out with athletes. I have an amazing network of local healthcare providers, practitioners, and specialists that I feel very confident in referring to. And funny thing is, I have gone back to the baseline testing, which I didn't think I would. And I do so because it's a tool. It's a tool, kind of like massage is a tool. It's a tool much like acupuncture is a tool. It's just a piece of a puzzle. It's not the be all end all, and it's not meant to be the be all end all. It's meant to give me some information that I can use again at the very end to determine whether or not I feel that athlete is ready to go back. So that's baseline in a nutshell. I am going to send Kyle a link, and I'm going to have you guys all do the neurocognitive piece. It's on a computer, takes anywhere from 20 to 30 minutes, and I can log in and I can see your results. And remember, not a test. You're not going to pass or fail. It simply gives me a baseline. And it'll be something like questions like the word green is on your screen, but it's written in red. And the question is going to ask, what color do you see? Some people will say, well, green. No, that's the word you see. And some people will say, well, the word green is written in red, so the color I see is red. And that's the ability to decipher the question, relay the information from the brain to answer the question. Those are the things that the baseline is going to test. And that reaction time and that perception of what it's asking is the information that I would need if any of you ever sustained a concussion. So that's baseline in a nutshell. To diagnose. So there's an on-field diagnostic tool, and then there's a diagnostic assessment that we do in clinic. So the on-field on ice in sport is called the SCAT-5, which is called a Sport Concussion Assessment Tool. And it is a standardized tool that we use, again, all over the world. So no matter whether you're an Olympic athlete or you play for FIFA or whatever level of sport you play, the SCAT card is recognized at all levels throughout all sport. And the nice thing about it is someone says, okay, what did the SCAT-5 say? Da, 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 da. Okay, so I will know the lingo, they would know the lingo, and everybody has an understanding of what it is testing. So the SCAT-5 is just a piece of paper that most trainers will hold. Sometimes it's a coach, depending on the level. Sometimes nobody has it, which they should. Any team you play for, they should have a sideline SCAT-5, so a Sport Concussion Assessment Tool. And what it does is it gives us the red flags. It's going to give us observational signs. So regardless of how trained the person is, they just have to read off the card and they know what they're looking for. It's going to ask some memory questions. It's going to ask what's called a Glasgow Coma Scale, which are reflexes and some eye tests. And then it's going to do a C-spine assessment. And it's all very, very quick. So the red flags would be like, did the patient suffer a seizure? Did they lose consciousness? Are they verbal? Are they able to speak with you? Those kinds of things. And if any of those are yeses, you're shipped to emerge. 911's called and away you go. The rest of the card is not asked. Nothing else happens. If there aren't any red flags, then the trainer goes on to step 2, which are observational signs. So you ask around, okay, I didn't see the hit. I didn't see the elbow to the head. So you might ask a teammate. You might ask the referees. You might ask the coach, okay, what exactly did anybody see? Did they hit their head on the court? Did anybody fall on them? How many impacts happened and those kinds of things. So you're looking for observational signs that someone else can give you details on. And that gives you an idea of whether or not this could be a concussion. Step 3 is going to be memory. So you're going to ask simple questions. Where are we? Who scored the last goal? What did you eat for dinner last night? What time did you go to bed? Questions that they should easily answer. What month is your birthday in? And you don't want to trick them here. This is just to see how good their recall is. Very, very simple things. Having to pause to answer, like, what did you have for dinner last night? And they go, spaghetti. It's still a good answer. But it's just whether or not they can go into their memory bank and spit out the answer. So those are the memory questions. Step 4, a little tougher. There's some eye tests that people will have to read very precisely on, but it just, goes through some simple, smooth pursuits and things to make sure that the eyes are functioning. The interesting thing is the connection between the brain and the eyes. I can get a lot of information from the eyes. Are their pupils really, really big, or are they constricted? Is one big and one small? Are you in a lit room, which means, are the eyes able to take in the light and react, or are they going off doing different things? So that tells us the level of brain injury. It doesn't tell you so much about the concussion at the start, but is this another 911 call? Could there be a torn retina? All those kinds of things. Some reflexes. So if there is a brainstem injury or a higher center brain injury, they're going to lose some simple things like the patellar reflex that everybody's had done once or twice in their life. So those are step 4. Step 5 is a C-spine assessment. Little tougher to do without the proper qualifications, but regardless, you're just going to palpate the spine, some range of motion, and just see if the neck is involved, because the neck does overlap concussive symptoms. And sometimes it's just a sore neck, but half the questions or half the symptoms do overlap with a concussion. So sometimes that makes it a little tougher to differentiate between the two without the proper testing. But that's a scat card, a quick version. Feel free to look it up if you want a little bit more information. But again, it would be something that's in your hands. It's something that we would hold and something we would do as a sideline assessment tool. I don't use it whatsoever in the clinic. My assessment in the clinic is much more precise and detail oriented. However, that's a quick way to know, is my player going back on the court? Is my player sitting for the rest of the game, or is my player going towards the hospital? And that gives them the information to determine that. So that's the sideline. So the clinical assessment is quite lengthy. We have to test something called VOMS, which is visual ocular motor screening. I'm not expecting you to know that. It's a more in-depth vision test. Gives us an idea if there's any disorientation. We test a full neck assessment, full neurological assessment. We do a series of balance tests. We do vestibular testing, which is kind of like dropping a pen on the floor, having the person pick the pen up and come up really quickly. Does that kind of go, woo, make them feel worse? We do memory. We do things like the months of the year backwards. Try that one. We do different number sequences. So I would, for example, say 734, and I would ask you to say 734, but give it to me backwards. And you would go 437. But if you've got a brain injury or a concussion, you may not be able to flip those numbers as easily. And sometimes you get them wrong. So those are all things that I'm testing. And again, I'm testing whether or not you can take normal, regular, simple information from here and give it back to me. I do a reading test. So here's a paragraph. I want you to read it. I ask a few questions. Were you able to read it? Did it make your headache or whatever, your symptoms worse? And ask a few questions to see if they were able to retain the information. So that's the cognitive piece I do in the clinic. Now, depending on how bad that gets the patient, and a lot of times I have to divide these up in several stages because they just simply can't get through them all in one sitting. It makes them very nauseous, very disoriented, and unfortunately very not well. The other thing we do when a patient comes in with a concussion, and it's part of my assessment, is a series of symptoms, and they're from 0 to 6. And there's two lines of them. The ones on the left are typically questions that would mimic like headache, dizziness, nausea. Are you having trouble falling asleep? Are you having trouble staying asleep? So pretty simple questions that could be migraine related, pain related, mood related, all those kinds of things. And then the right-hand side are more the anxiety. So are you foggy? Are you having sensitivities to light, sensitivities to noise? Do you have to wear like your sunglasses? Are you having trouble around big groups of people? Are all those kinds of questions. Now again, the symptom chart, as useful as it is, overlaps migraine sufferers, anybody with anxiety, anybody with depression, anybody that was stress, anybody that already has sleep issues. So it again gives me a bit of information, but I can't put all my eggs in one basket. Very useful tool if there's no other extenuating circumstances, but a very complicated tool to use if there's anything else going on, because the numbers remain high, and it makes it really tough to use as a return to play assessment tool. Unfortunately, we do use it, but it does complicate my factors tremendously if there's another issue. And there are a lot of anxiety in concussions. So a little bit more about a concussion. I don't know if anybody's had it, but it's a very unusual injury in the sense that a lot of athletes, we'll just stick with the athletes, feel almost like an outer body experience. You feel very much like you're outside your body looking in. You don't feel grounded. It doesn't feel like your feet are touching the ground. Objects are moving, but you can't figure out quickly enough what they're moving for. Maybe you're moving, maybe they're moving, maybe the room's spinning. And it's a really difficult time. And rolling an ankle sucks, but it doesn't involve so much mental energy as a concussion does. A concussion really drains physical, physiological, emotional, and mental. It's very, very tough to deal with a concussion. And I tell all my athletes and all my people, don't be a hero. This is a really hard one to understand. And like I was talking about last week about the metabolic crisis and the energy crisis, well, those make any type of emotional or mental issues 100 times worse. So not understanding what's happening to your body, rolling an ankle and knowing it's puffy and it's sore and it's bruised, that makes sense. Trying to figure out why you can't watch TV for more than 10 seconds without feeling like you want to vomit, or you can't have a conversation with more than one person because you got 3 friends talking and it just feels like everybody's doing this to you. That's really hard to maneuver through, and it's really, really hard to cope with. And coping is a really, really important word. One of the things that happen in concussions is that your brain is now injured and it can only handle one signal at a time. So whether that signal is a pain signal, or you're reading something and you're trying to compute it, or you just moved quickly and the brain's got to figure out where you are in space, that's all it can do, one thing at a time. So one thing that gets sidelined immediately is your ability to cope. Because a coping mechanism is a mechanism that allows you to cope or to orientate yourself with multiple and numerous signals. That's your coping mechanism. And when you have an injury, you can't cope. And a lot of people don't understand why they are an emotional wreck. Why is it that my dog barked and I'm crying? Or my mom just asked me to do something and I don't remember what it is. And it's because those little things that you would have naturally have figured out, dealt with, and moved on, you're not able to do anymore. And that's a really tough thing when you're trying to be an athlete, a student, a brother, sister, boyfriend, girlfriend, whatever it is. You all of a sudden can't be all those people to all those people. And it becomes a real problem at home, in relationships, with your teachers, with your coaches. And if you've got people around you that don't understand that, then it puts a lot more strain and stress on you, which is where I'm getting to next, which is the education piece. So I do a lot, and I put a lot of emphasis on education. I get probably a 30% reduction in symptoms just with explaining those pieces of information to my concussion people. Because knowing that, I hate to use the word normal, but it is that this stuff is expected and is normal after concussion, really does lower the anxiety in patients. So I spend a lot of time right off the hop educating. Now here's what I educate. I tell you what a concussion is. I give you a document called sleep hygiene. And when you go into your energy crisis, which is one of the things with a concussion, your body shuts down. So you sleep and sleep and sleep and sleep and sleep. That's okay for a few days. About 72 hours, I let that go. But the second that 72 hours is up, I don't care if it's in the middle of the summer, I want you up as though it's a school day. I want you eating breakfast at the same time. I want you showering at the same time, and I want you moving. I need your sleep patterns to remain as normal as possible. Because if I allow you to sleep and sleep it all off, I'm going to have a really hard time returning you back to school, back to sport, or back to work when all of a sudden 6 months later, I'm like, okay, time to go back to work. Now you got to get up at 6:30. One of the symptoms of concussions is I'm always tired. How do you decipher whether it's a concussion symptom now, 6 months later, or if you've just created a new routine because you used to sleep all the time and now I'm making you get up? So I am very strict on the sleep hygiene policy. And the other policy I'm really strict on is I don't desensitize you. Years ago, we would desensitize you. And what that means is we would make you as comfortable as we can make you. You want to wear sunglasses in class? You wear sunglasses in class. You want to sleep? You sleep. You want to take Advil? Take Advil as often as you need. We don't do that anymore. We suck it up. If I put sunglasses on your eyes to be in class, and then all of a sudden I have to take them off, we have now created a sensitization of the eyes to adapt to those sunglasses. And again, now you've got to adapt to the lights, the fluorescent lighting, and it's going to cause a headache, and you're going to think your concussion is back. So if I desensitize you, I have to then resensitize you. And I don't want that much work. So a lot of the philosophies and the belief systems behind how we care for concussions have changed drastically. And a lot of what we do now is make you uncomfortable so that you stay on a routine and so that we've got something to work forward, not backwards from. So those two things are pretty important pieces, okay? The other bits of information, I will put you on supplements. I immediately put you on magnesium and I immediately put you on omega-3s. Sometimes we do some blood work to see if there's any other deficiencies. Vitamin D in the winter for sure. Sometimes we've got to do vitamin B12, sometimes zinc because that's an immune booster. So there's a lot of healthy and good things that we can do that boost brain healing and decreases the metabolic changes that happen in these crises type of events. So that's a nice, easy thing, and it works really, really well. Now, it's not like taking an Advil. Taking an Advil is an immediate relief. Taking a supplement like magnesium is longer to work. But that longer to work means that it's doing something, it's not masking something. So I don't mask, I fix, or I reverse, or I correct. So the way we go about these concussive symptoms is a little bit more long lasting. But it's not that we don't allow Tylenol, we do. It's just that, again, I'm not going to sensitize you against something that I eventually will be taking away. We also talk about an anti-inflammatory diet. So any type of trauma causes inflammation. And from here down, go nuts. From here up, I don't want any more inflammation. I want this restricted because inflammation basically prolongs already complicated symptoms. So an anti-inflammatory diet means we remove sugars, we remove white carbs, very, very simple things just to bring the inflammation down naturally. We might use arnica, we might use turmeric or curcumin, and those are just spices that we can use again to control inflammation in the body. So those are the big education pieces. Obviously, we go through the physiology behind concussions and stuff like that. I educate every single time you come in. Sometimes it's reinforcing, sometimes it's a modification to kind of explain where you are in your protocol. But regardless, we keep educating. So that's kind of like all part and parcel for the diagnostics. Now remember, there are 6 types, and we do determine the type during. So once again, we have vestibular, which is the balance, ocular, vision. We have mood, very common, anxiety, very common, cervicogenic, which is probably one of the most obvious ones I see are most common, and the migraine headaches, which I see a lot in my girls. So those we have to differentiate because that's going to determine the next part, which is the algorithm and the flow chart that we do with the treatment. I'm not going to go through it all, but I'm going to do it really quick. So we automatically increase the blood flow through the neck. We repair all the soft tissue traumas. I do 2 in the head. I do 2 in the jaw area to make sure there isn't anything impeding blood flow to the brain. Those are the soft tissue. We get 20 minutes of aerobic activity every single day starting day 1, and we move from there depending on what you do for a living. We modify the length of time you're on screens. We modify basically what you're doing at work, what you're doing for your sport. We try to take away as little as possible. We will, if it's a visual concussion, take a lot of your screen time away, allow you to do podcasts, things through the ear, that kind of thing, so that you can still stay connected. But everything's just modified. We may take away for a short time, but it's not that frequently. Then once we've got a grasp on that, if it's a visual concussion, I will send you to an optometrist. If it's a vestibular concussion, I will seek a vestibular therapist. If we have, again, speech impediments, I will talk to a speech therapist. If we're looking at really significant eye issues from the optometrist, we go to a neuro-optometrist, and I deal with Dr. Kincaid in North Bay. Now, if I'm on the mood and anxiety side, I will refer to Dr. Gagnon, who owns I'm losing it. I can't think of the name, but he's a psychiatrist. He has social workers, and they do biofeedback. So they retrain the brain to adapt to the stressors. And they deal, obviously, Headway Clinic, sorry, I knew it was going to come to me. They deal with how to cope, how to retrain and relearn. And of course, again, any of those anxiety and depression type factors, they help me with. And I stick to more of this sports specific stuff. Sometimes I use an OT, which is an occupational therapist, to help with the desk stuff. How do we take a stack of files this big and say, which is causing someone stress and anxiety, take that away, give them one file, and teach them how to time manage again. Those are all in this spreadsheet and in this flow chart. It's quite extensive. And then at the end of that, the return to play stuff, which is what you guys need. There's 3 levels. So first, there's a return to train, meaning that your symptoms are settled. Now I need to exertionally check if you can handle the increase in heart rate and the increase in blood flow. So I do something called the Buffalo Concussion Treadmill Test from Buffalo Sabres. And it's a stress test. I put you on a treadmill, and every minute we elevate the incline. We check to see how you're doing. If all is well and your symptoms haven't increased, we will get you to run. Now, if that increase in heart rate and increase in blood pressure doesn't cause an increase in symptoms, you've passed. If it does, we stay where you are, and we now train you at that level, but you can't go back to training with your team. Once you've passed that, then we can get you back into your training. So you are now doing your dry land, off ice training. And we leave you there for a few weeks. If nothing changes in your symptoms and you're still really good, then we do something called the Chicago Blackhawks testing. And that's a series of more significant exertional testing. So now we're doing 180-degree turns, right? We're doing spot stuff. So you touch your left foot and look up to your right arm and make that head move. I do something called blaze pods, which are these little pods that light up, and they're on my iPad. So I can, depending on what sport you are, I will create a sequence of light, flashes on and off, depending. So if you're an upper body like volleyball, it'll be up on the wall. Sometimes you have to hit it with your stick. You guys might be, tapping on the floor, tapping on the wall, and causing those. So now we've got hand-eye, we've got sequencing, we've got vestibular. So it merges all these things. We do burpees, we do somersaults to make your head go. So the Blackhawk testing is much more aggressive form of testing. If you pass that, then you get to go to non-contact practices. And non-contact meaning you can do drills that don't involve another player. If you're on the ice, you can't scrimmage, you can't do anything that could harm you, you're not fully recovered. But again, you're more involved with the team dynamics, and we're getting you back on your field or your court or your ice. If that goes well for about a 2-week period, now we're going to return you back to contact. That requires a doctor's note. So we now send you to your family physician. We give them all the criteria of all the testing, and we say now we need them to be bumped and moved a little bit to make sure that you're not squeamish, afraid, overprotective. Do you buckle out? Do you try to not be in that, in that area of scrimmage where you might get the bump? All those kinds of risk factors, which would cause, another problem. Or are you good to go? Is your brain clear and your risks are low? And then if that's good, then you get to go back to your contact practice. And if the contact practice is good, no increase in symptoms, I talk to your coach, I talk to your teammates. How did they look? Did they move well? Did you get into the corners of the ice? Did you, protect your player? All those kinds of things. And if the answer is yes, 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 I send you back to play. And that's basically your return to play in a nutshell. Now, return to learn is a little different. Kyle, being a teacher, would know there is a document that school board requires us to fill out and a bit of a protocol. I do that one as well as my own, and we make sure we check off all the boxes. And that's just to make sure that you are indeed capable of learning and you're not just sitting there and retaining absolutely nothing. But that's not really something you guys have to worry about. That's something that Kyle as a teacher, me as a therapist, and your doctor and the school board would all do for you. It's kind of like giving you a little bit longer to do your presentations and some of your work, maybe skipping a test or two, maybe giving you an extra week to study, all those things to make sure that you guys optimize your education and you guys aren't losing marks or failing tests because you have a concussion. So the connection and the relationship between us and your education system is really, really, really good. And everybody works really well together to make sure that you're not penalized for having a concussion. So that's really changed over the last 5 years. And that again is something I'm pretty impressed with. So that's the concussion baseline treatment return to the world in a nutshell. Again, it's stuff that we do for you, but I'm going to give you the heads up. It's lengthy. People think, okay, well, I'm symptom free, so I'm going to go back tomorrow, right? And it's like, nope. You have 3 stages and you have to pass all 3 stages and you have to have 24 hours, off between those stages, and you've got to pass the next stage. And then by the 3rd stage, you need to make an appointment with your doctor, which could take 2 more weeks and on and so forth. So something that you think you might be able to return in a few days could very well take 4 to 6 weeks. So just, keep that in mind. If you get a concussion, it's not a quick return. It's 7 to 10 mandatory days off, regardless of the severity. And if it's more than a mild, you are with us for a while. Doesn't mean you're not going to go through each, level quickly, but it's still a time restriction. And because of Rowan's Law, our hands are tied. There's nothing your coach can do. There's nothing your parent can do. And there's nothing I can do, which is all in all protecting you as an athlete. So as frustrating as it gets and as stressful as people might make you feel, it is to protect you, your brain, and your future. So keep that in mind if you guys ever sustain, hopefully you don't, but sustain a concussion, that it's all surrounds your best interest. And the good thing is you guys don't make the decisions, we do. So nobody can blame you for it. So if anybody has any questions, you can contact me, email me, text me, whatever you'd like. Next week, I'm going to have Troy Beauregard from Supplement Sudbury come in. Even though we've done a supplement talk, Troy has been a personal trainer. He's trained hockey players mostly. He works out of Inspired, and he has started his own online supplement company with the COVID changes. But the reason I want him in is I would like you guys to get me some questions. I know I'm an all-max girl. I'm a female, and I'm in my 40s. So I'm not saying where, but I'm in my 40s. So I would like you guys to openly ask questions. There's no judgment. There's no criticism here. I'm going to pose them to Troy. You guys don't even need to be here. We'll record it. I realize it's the Tuesday after the long weekend. I'm not saying who asked the questions. They're going to be anonymous questions. Troy is going to provide his response, and hopefully that will give you guys some answers to maybe something you don't want to ask. And again, it'll be completely anonymous. I'm not going to say who said it or why. And so please feel free to ask as many questions as you want answered on supplements, any forms of supplements, vitamins, proteins, branched chain amino acids, fads that are out there, things you've heard people talk about, energy drinks, pre-workouts, anything and everything that's out there. Let's ask the questions. Let's get your answers to you so that we know that you guys are on the right track. Everybody have a great week, great long weekend. Have a happy civic holiday, and we'll see you guys all on Tuesday. Take care, everybody.